Hello again, everyone, and welcome back. It is my great privilege and honor today to introduce my special guest, Mike Restuccia, CIO of Penn Medicine in Philadelphia. Mike, what a pleasure to have you on the show and welcome.
Patty, thanks so much for allowing me to join your show and your podcast.
Thank you so much, Mike. I appreciate that. Mike, what does your post-COVID normal look like at Penn Medicine? I guess that's the topic on most people's minds today with, the vaccinations and everything. What does the new normal look like? What are you really preparing for in the next phase, especially from a technology standpoint?
Yeah, um, Patty, in many ways, the post COVID normal looks like a lot like the pre COVID normal, plus a plethora of other responsibilities and activities. And thus, you could say the post normal will be even more frenetic than in the past. And, those things that we'll see much more of in addition to what we had been focusing on pre was, expansion and run and maintain and growth and all those EHR type things. When you look at the post, it's all those things plus more tele, plus more engagement, plus more expansion, plus more monitoring of patients in a remote manner, all big lifts from an IS perspective. So, in many ways, I feel like we had a pretty substantive role and job as a team pre-pandemic, and post, it just doubles or triples, and there's no sign that it's going to slow down.
That's a actually a very interesting observation. Now, we've seen that in the wake of the pandemic, a lot of the telehealth modalities that you alluded to and virtual care models in general have gained a lot of ground. Now, when you look at the broad marketplace and the trends in the healthcare sector, Mike, and also changes in the competitive landscape, digital health startups and big tech firms and non traditional players and so on, could you maybe talk to us about the top two or three trends that you tend to track at a leadership level at Penn Medicine? And how do those trends drive your technology priorities?
Yeah, for sure. We'll start with tele. Pre-pandemic, we were doing a few hundred televisits a month. At its peak, in the middle of the pandemic, we were doing over 8,000 televisits a day. And now it's plateaued since to somewhere around 3,000-ish per day, but that's still significantly higher than where we were pre-pandemic. And so tele is, as mentioned previously, is here to stay. It's an area that we really need to pay more attention to. I think from a maturity perspective, we have a pretty good solution in place. But there are other vendors, to your point, that are rapidly advancing their telemedicine delivery capabilities. And to us, integration with our electronic health record is critical. Our patients love it, our providers love it, and getting more integration in the future with our electronic health record, I think, is a key activity for us that we're looking at. Changing gears a little bit, you had mentioned, and I had mentioned, remote monitoring, whether in the home or in particular, Patty, within our ICUs, across our 6 hospital enterprise, we have almost 250 ICU beds. And each one of them, virtually each and every one of them, is now monitored with a camera connected to a central location, thus tele-ICU, for 24/7 monitoring and care. It helps, obviously, from a delivery of care perspective. It helps from a responsiveness perspective. It also helps from a staffing perspective because those 6 hospitals are located basically in a 150-mile radius. And so having proper staffing for those locations is mission critical. And then I think the third thing that I would speak to is just enhanced patient engagement. And that engagement can take place either predominantly through your patient portal in order to deliver results, in order to schedule appointments, administrative types of tasks, bill paying, communicating with your clinical team, but also from another mechanism, Patty, and that is us actually pushing information and alerts to our patients. And we saw that pretty significantly, again, through the pandemic, and it was a new opportunity for us where when we began to reopen our patient clinics after having ambulatory clinics after having them shut down, and reopening our hospitals for non-essential surgeries, we went through and began a texting campaign, an interactive texting campaign that communicated with patients just on their phone and basically said, hey, we know you're coming in 24 hours or 48 hours. We want to ask you a series of questions and just respond with one or two or yes or no to these. Very simple. Based upon the responses to those questions, the patient would either be cleared or the employee would be cleared to come back to work, patient would be cleared to come to the clinic, or it would be triaged off to a care team so that if the patient responded, I've really been having these symptoms and they're COVID-like, probably don't want that patient arriving in the clinic. We want the care team reaching out to them at that point in time. Another good example of engaging the patient through some type of technology, albeit pretty low-level technology.
Yeah. How have your patients and your consumers responded to the shift towards a more digital mode of engagement? And for that matter, how has your caregiver community responded? Because it's also important for the caregivers to be familiar with the technologies you use. You need to train them and maybe change some workflows and so on. Could you talk to us a little bit about what that experience felt
Yeah.
like for you?
I'll start with the patients first, and it's a bit more anecdotal than it is scientific responses. But I think what we consistently heard from the majority of patients, and there is some differentiation based upon perhaps age or technical savviness or whatever it might be. But people were thankful. Patients were thankful that we were paying attention, that we were contacting them, and we showed we were concerned for their health as well as the health of the caregivers, as well as the health of any other patients that might be in the general vicinity. So I thought that, and overall was a pretty big win. And anytime you get a chance to engage a patient in a positive way and make it positive, that's a big win. And I think we really extended our brand loyalty, and we expanded, our care and concern, and communicated that to our patients. From the caregiver's perspective, you're exactly right that it's a pretty big change in workflow, as you have to go through multiple steps just to see a patient. Overall, again, I think the response was mixed, but overall it was much more positive than negative because, interestingly, there was a segmentation of those physicians that were very comfortable using the technology and actually embraced the concept of using a telemedicine type approach. They could see more patients. There was less downtime. There was a higher adherence rate to the meeting, thus less no-shows. There was just more flow that took place. On the other hand, there was still some that said a televisit is okay occasionally, but I need to see that patient. I need them next to me. I need to observe more than just how they're interacting through the screen.
Yeah, just to stay on that for one more minute, stay on that topic. You mentioned that your telehealth visits went up to about 8,000 a day from about a few hundred a month. And then they've dropped back to about 3,000 a day today, which is kind of the typical experience across the country as well as we start opening up and patients start coming back into the hospital and so on. Have you reached some kind of an equilibrium, you think? Are you designing the future based on this equilibrium? What does it look like for you going forward?
Yeah, you hit the nail on the head. I think we've reached an equilibrium for now. And remember, there's a lot of pent up demand to come back and see in person, which sort of impacts the decline and that plateauing. My sense is that we will have another bump in our use of and it'll be for several reasons. One is we will have gone through that pent up demand for in person visits. Secondly, I think we've learned that not every visit has to be in person and that you can have some balance or ratio of visits per patient. Maybe it's one inpatient, one in person, and two virtual visits type of an approach, or 1 to 3, whatever it might be. I think we're figuring that out. And third of all, I think the strength of Penn Medicine is its breadth and diversity of care that we provide. And as we can expand that further, it will support more and more tele type of engagement.
Yeah, you mentioned breadth. Now, Penn Medicine, of course, is a very unique institution, the first hospital in the country, quite a historical heritage there, if you will. And of course, you're a leading academic institution, a research institution, and a healthcare delivery organization. So that makes you, very unique in terms of your mission. And when you look at it from a technology standpoint, especially from the point of view of your strategic technology partnerships to drive your mission, how do you look at it? How do you harness all that your incumbent technology partners have to provide to you, but also tap into the innovation ecosystem, if you will, to drive the organization forward?
So let me start with our partnerships, Patty. And maybe this is where it gets a little boring, but we believe in few and deep partnership relationships. We are not an organization that has 5 different vendors providing 12 different solutions for the same cause. We will generally go with one vendor across the board and implement common systems, centrally managed, collaboratively installed. And I think that works really, really well. Whether it's on the networking side, the EHR side, whether it's telephony, whatever it might be, that's our approach, because standards and systemness across the enterprise is our approach to things. And as you mentioned, we are focused on patient care, research, and teaching. I think there's 121-ish academic medical centers in the country, and we're one of them. And it is a unique mission. It requires more and more integration amongst those 3 towers than ever. And when we talk a little bit maybe later about our approach towards genomics and bleeding that into patient care and precision medicine and precision health, these are exciting times. That's where it gets real exciting and flashy and sexy in the types of things that we're doing that really are transforming care. But from a partnership perspective, several solutions at most, deep relationships, common across the system is really the attributes that we seek.
Now, I'm sure that your strategic partners deliver much of what you need from them, but in all likelihood, they don't deliver everything that you need,
They don't.
especially when it comes to maybe some of the newer kind of capabilities that you're looking for in an emerging
Yep.
future. So, how do you when you realize that your existing partnerships maybe don't have what you need, how do you go about sourcing it from elsewhere, or for that matter, building it internally?
Internal.
Do you have a sort of a could you talk to us about your approach?
Yeah. Uh, Regardless of whether our partners are providing the proper solution or not, we're always looking to innovate. And that's within corporate IS as well as in partnership with our Center for Healthcare Innovation, which is a close ally and very dependent upon corporate IS, as you might suspect. So, Center for Healthcare Innovation is part of Penn Medicine. It's led by Dr. David Ash and Roy Rosen. And they have a team that's focused on what is that next thing we should be doing in order to either improve efficiency, care, accelerate research. And their team is very focused on new technologies as well as new workflows and new endeavors. They are very dependent upon corporate IS for those networks, for the data, for the project leadership in order to advance some of those causes. Generally, the way it works, Patty, is the Center for Healthcare Innovation will identify an opportunity. They will organize the appropriate constituents because, as you know, there's more than IS and more than big thinkers that need to be in the room. There needs to be operational assistants, clinical assistants, perhaps research assistants participating. They get that organized and then generally perform a proof of concept to see if the thought really does hold water. If it does, then we try to do a pilot. And then we look, once the pilot is completed, to determine whether corporate IS should try to scale it across the enterprise. So I think that's kind of the approach we've taken internally in order to advance our causes. And often, whether it's improving access to a particular department, whether it's making care more convenient for patients and introducing mechanisms that patients don't have to come on site as much, be treated more in the home. Those are like examples of how the Center for Innovation has advanced certain causes.
Now, for digital health startup founders listening to this discussion, and they have a question on their minds, and very often I get the question from them: how do we reach out to Mike or someone like Mike to showcase our solution or our capability? What's your advice to those who want to be a part of this and may have an interesting story?
Yeah, people find ways to get to myself and Roy Rosen and Dr. Ash. There's no challenge there. We're pretty public figures. And so, we encourage them to reach out and share their ideas and their thoughts. And we look at them. We look at them all. You know, I think whether it's patient care, whether it's access to care, whether it's engagement with the patient, I think all those things are things we're readily looking at on a daily basis to try to improve things. And, as you highlighted at the start of this talk, we've made a lot of advances because of the pandemic. And there's more to come. So I think we have this spirit of being able to introduce now, and things that were once thought to be not possible are now very state of the art and very day to day and very probable. And certainly, who would have thought you could go from 300 to 8,000 televisits? Seemed impossible. But when you focus on it, you can get it done.
And it
I'd
did
also
happen.
add, Patty, that we do have many people that reach out to us and find their way into the Penn Medicine ecosystem environment through some way, shape, or form. It might be through a friend they have here that works at the health system. It might be through a board member. It might be through some other channel. And it just arrives on our lap. And hey, here's a really good guy with a really good team and a really good product. And so, Mike, you guys ought to do it. Well, the first few times that scenario took place, we sort of took a stab at trying to figure out, wow, this person was recommended and their team, their companies recommend, they must be good. I think what we learned, Patty, is that just because a person says they're good doesn't mean they necessarily are. And we spent a lot of cycles trying to understand the firm's stability, their product, their ability to need support, their ability to secure any data that we might share with them, their potential for long-term sustainability. And as a result of a few, I would say, initial misses, we introduced a committee. It's a multidisciplinary committee that I co-chair with Roy Rosen from the Center of Healthcare Innovation. We call it the New Technology Review. And before we go too far with any new potential partner, we ask them to come through, tell us a little bit about themselves, and then present to the committee so that we can see them one-on-one, face-to-face, and better understand what their capabilities are. And that process has dramatically reduced our misses. It's really improved our efficiency. It's improved communication and effectiveness as we move forward with some of these newer technologies and firms. And overall has been a big benefit to smoothing the waters here and keeping people focused on what's most important.
Staying on the topic now, obviously, when you get new solutions in, you have to make sure it works seamlessly within your overall technology environment and also deliver a seamless experience to whoever is consuming the technology, whether it's your caregivers or your patients or members, as the case may be. And that can be quite a challenge in the healthcare context. What what are the top maybe one or two challenges that you have had to overcome, especially when harnessing innovation from the marketplace as opposed to innovation from within your existing technology partnerships?
Yeah, I think it's always, and this isn't just recently, but it's probably we've all experienced in our careers. It's the overselling, the overpromising, and then the under-delivering. And some of the firms have really solid sales teams or business development teams, and they have a really great vision. On the flip side, they don't really have the delivery mechanism tied to it. And so, you get the sales pitch, you get the, hey, it's going to be great. And then the delivery team comes in and you end up short. And then that's where my team ends up having to cover and pick up the slack, because by then the idea has been sold, it's been budgeted, leadership's expecting some results. And when the vendor falls short, that to me is one of the biggest problems we've experienced.
Right, right. Let's switch topics for a second. We've in my podcast, we've had some of your leadership team members come and join us as well. And one of the things that has fascinated me about some of these conversations, in fact, I want to talk about two of them. One of them is let's start with the first one, which is your data and analytics program. And you've made great strides with your data and analytics program. You referred earlier on in this conversation to genomic data and how you're harnessing genomic data. Can you tell us a little bit about what is the overall mission when it comes to your data and analytics program? How are you supporting the three different missions? The academic, the research, and the healthcare delivery side of it, and maybe a couple of big successes or learnings you've had in the journey.
Oh, for sure. I think you mentioned the term, what's the vision? And I'm pretty sure I'm not the greatest one with vision, but members of my team are. And, using that construct of common systems, centrally managed, collaboratively installed, if you keep that as the overriding umbrella, the spirit around analytics was we need a centralized location where we could house patient care data, research data, whether it's biobanking, biotissue, genomic data, and any other types of demographic data into one location. We call that location now Penn GNP. Penn GNP is Penn Genomics and Phenotype. And that data is initially loaded in raw data format. So if someone wants to reach in and grab raw data, they can, if they're savvy enough to do that, the data is available for them. We then move up a tier and we synthesize that raw data and homogenize it into common data definitions, common data model, and accessible with common tools. Probably a little bit easier then for an end user to reach in and grab what they want at some point. But again, it's a common location that we're zeroed in on. And then finally, what we will do is move that data off into data marts. So we might have a patient safety and quality mart. We might have a clinical care mart. We might have a research mart that has just that specific domain data associated with it. We do all this now through the Azure cloud, which we found, again, makes access to the data even easier, utilization of standard tools that are accessible to all. And really now, Patty, with a goal of having our end users be less self-reliant on our data access team and more reliant on themselves through self-service.
Right.
And I do think that's going to be that will continue to be a big lift for us, as it is for many other organizations, in how we communicate and educate that end user community and liberate the data for their use, and so that they're not as dependent upon us. So I think some of the big successes that perhaps we've seen, and you touched upon one, is we were one of the first, if not the first, to begin to take discrete genomic lab results from one of our lab partners and integrate that into our electronic health record, and put a whole program in place on how to make that work, utilizing our genomics team, genomics counselors, members of our cancer center, and then certainly our end user clinical staff community, and making sure that when this genomic result shows up in a patient's chart, the patient is well aware of what had, what the result was, and then what the implications are to the caregiver, because many of them require some level of training and education on how to discern what that variant result might be.
Yeah. Of course, when we talk about data analytics and insights, we have to talk about AI as well. And the term AI, of course, means a lot of things to a lot of people. And if anything, the buzz around AI just seems to be increasing. And I'm not sure, what degree of success people are accomplishing consistently across the board. But I'd love to hear how you've been able to leverage these advanced analytics tools, machine learning, artificial intelligence, whatever you choose to call it, in the context of your data and analytics programs.
Yeah. So underneath that banner that I talked about earlier of over promising and under delivering, I think AI fits that banner and fits in that bucket. And I don't think I'm the only one that would say that. Certainly, you're more connected in the industry than I am, but I do have hope for it because much like innovation was a four-letter word a bunch of years ago, AI is becoming a four-letter word because it's just overpromised at this point with limited tangible results. But it doesn't mean that we're not making strides towards it being more and more beneficial. We are taking a two-pronged approach towards AI. The first is a top-down approach, whereas we will work with members of the vendor community who claim to have this algorithm that if you give it the right data in the right format at the right time in the right sequence, it'll tell you something. It might tell you whether you're going to have a higher no-show rate, whether there's going to be a health deterioration, whether sepsis is on the horizon, whatever it might be. And that's our top-down approach, where globally we'll just lay it over the enterprise. And we've had minimal success with that so far. We also have a bottom-up approach. So I have a team of 7, 8 data scientists that work in a more discrete manner with our end user community. And they work with very passionate clinicians or researchers who claim they have this great idea. And if only, they've observed certain things, if only they had data on those things, it could be combined again in some way. We could develop an in-house algorithm that would bring great benefit to the group. And I think, we've seen that particularly in at-home care. We see that in palliative care, where we've predicted certain occurrences that will take place. But that's in a very narrow tower. It's not as broad as my top-down approach. So
Right.
we will continue on both streams because we think there's really great hope. We are big believers that there's great, that the answers are in the data, or are often in the data. And we just have to get better at figuring out how to combine that data in order to generate a proper result.
Right. I think that's a very well balanced articulation of the promise and the potential and the actual performance of AI today. And like you, I'm optimistic about the future of AI as well. So, Mike, one of the things that I've learned about you is that you spend a lot of time on your people, uh, perhaps more than half your time on your people. Tell us about what you do, and how do you ensure that you're attracting, retaining, and nurturing talent within the organization, because all of this technology and all of these new programs, they're only as good as the people who are committed to making it all work. So talk to us a little bit about that.
Yeah, Patty, when I joined Penn Medicine 14 years ago, uh, 95% of our IS services were outsourced to third-party vendors. And, that was done 20 plus years ago for a variety of reasons: cost containment, standardization of delivery capabilities. But what I was asked to do was help build a team that would insource the majority of those services. Because if you're going to have world-class clinicians and world-class researchers and world-class educators, you better have world-class IS in order to enable it. And you're generally not going to get that passion and commitment from a third party. So one of my jobs was to rebuild the team internally. That took about 3 or 4 years to insource approximately 95% of all of the IS services. And during that time, it gave us, me and my team, the opportunity to build a culture that was accountable, a culture that exceeded expectations, and a culture in which we were viewed as consultative and partners versus just those folks in IS. And I think building that culture has really put us in a position where we're attractive to those that we recruit. I often say, I say many things, but one I often say is really good people like to work with other really good people. They like everybody to be accountable. They don't want Mike to always be picking up for Patty, or Patty to be picking up for Mike, or whatever. Everybody wants to be accountable, and we want 100% of the people to be doing 200% of the work. I think our mantra outside of corporate IS that my colleagues here look at us as, we always deliver. And it's not always easy to deliver. And so people do go above and beyond, and members of my team are passionate and dedicated to exceeding those expectations and wanting to always be looked at in a favorable light. So I think that was a culture we strove to build. I've had the good fortune of working places prior in my career where I saw that culture. I thrived in that culture, and I wanted to replicate that culture. Now, we are a $280 million, IS operations business, annual IS operations business here. It's a big business, and a big business cannot function properly without really, really good people. And I feel my teammates here are really good people. I feel our leadership here is exceptional. One of the things that caught me, and I probably haven't shared this with you before or my team, is despite the fact we're Penn Medicine, part of University of Penn trustees, we really don't have an internal managerial training program. At least we didn't. And if you look at statistics and you look at surveys, one of the top 2 or 3 reasons why people come to work every day for that employer is they like working for their manager. They respect their manager. They believe their manager has their best intentions for them with their career and their personal work-life balance and those types of things. Well, Penn Medicine has subsequently introduced a managerial training program, but IS did it first. We did it on our own. We went out and formed a program, and we educated our managers on how to be not only good technically, but good personally in their management style. And that to me was one of the best things, we've done within our organization. I have over 100 managers. And often I think what you find is in a technology world, the people that become managers were the best subject matter experts in their technology. Well, I think we all know just because you're a really good C++ programmer or a really good infrastructure networking person doesn't mean you're a good people manager. And we had to bridge that gap. And we've done that through a series of internal trainings, hosting webinars, team meetings, book readings, book discussions, and team discussions. And it's really elevated our ability to manage. Each of my team has now been through 360 evals twice. So they're getting feedback from all around them, their employees, their leaders, their colleagues. All those things pay dividends, and they're investments in people. And I think if you invest in people, they'll respect you, they'll like the culture. And, the end result is really, really low turnover, really, really high retention.
That's so well said. And I also want to mention that you also publish a biannual sort of status, the State of the Union of IT and your accomplishments. And I have actually read the document. It's very informative, very well put together. Again, it's a big shout out to you and your team. And for those who are listening to this podcast or watching this, I strongly encourage downloading the document and learning a little bit about how Penn Medicine does it.
Patty, we'll be happy to share that link with you. It's our benefits realization is one document that states the financial impact corporate IS has on many of the larger projects. And we do that every 2 years. And then in between every 2 years, we do the State of the Union, as you mentioned, which sort of just highlights the big projects that we were working on, a little less on benefits, but more on the function of that particular project. And we do that because marketing our services is important. It's important to the external community to understand our end users, what we're working on, where that $280 million is going to. It's also really rewarding and refreshing to the employees to see their efforts in print and recognize that I worked on that. That was my project, that I worked with that department or that center or that entity. Um, Much like, we have a lot of new buildings that are going up within the Penn Medicine community. And often people will tell me, when I drive by there, I tell my kids I worked on that building. It's a sense of pride. It's a sense of ownership. And a lot of what Penn Medicine is about is that pride and ownership.
That's so well said. And I would be interested in taking a look at the benefits realization document, and I will follow up with you on that.
Please.
Now we're coming up to the end of our time here, Mike, and there's so much more we could talk about. But if you wanted to leave our listeners with one or two best practices or learnings, especially in the context of this transformation that the industry is going through. Call it digital transformation, if you will, because really health is going digital in a sense. What are the maybe one or two things that you would like our listeners to take away from your experience?
Yeah, I think first we have to recognize the unique situation we are all in. Any individual can make a big impact in some way, shape, or form. You see that within industry, you see that within personal life and social life. Any individual can make a big difference. I happen to sit in the seat of the chief information officer, and so I have a bit more influence than most. And I think what I have found is, number one, you need to be bold and you need to be selective, and pick your shots and go hard at them. When I joined, as mentioned previously, one of the goals was to insource the services, but that wasn't so bold, and that was sort of this is what you got. This is what we need you to do type of thing. I thought some of the boldness was way back then was saying we need to get to an integrated health record. And back then, everybody had their own little pet product or pet solution for billing and EHRs. Every ambulatory department had their own EHR, whether it was orthopedics or GI, and nothing connected. And, I think the boldness was, let's get to one. And being able to fight off all the reasons that people would give you for not getting to one, and continually representing what the benefits could be. And then, once getting approval and still having energy left, actually implementing that type of a solution. Today, that's not such a bold premise, but back then it certainly was, and it makes a big difference. Today, I think when I look at what is there going to be more of, there's going to be more genomics, there's going to be more data, there's going to be more innate engagement. So that whole precision medicine approach, we're focused on. We've restructured our corporate IS team to continue to maintain our EHR and continue to do things on the research side. But now we have a team focused on bringing those two together. And that's bold and it's unique. But as you have mentioned, Penn Medicine's a pretty unique place. There's only 120 of us academic medical centers. And so we need to take that to the next level and take advantage of that. Being bold and being selective and leveraging your position, I think are really critical, without forgetting all the day-to-day run and maintain type of activities that have to still take place.
Of course, make big, bold steps and swing for the fences, as they say. Right. Well, Mike, it's been such a pleasure speaking with you. Unfortunately, we are out of time on today's conversation, but I look forward to following your work and the work of the team at Penn Medicine, and look forward to staying in touch. Thank you once again for coming on the show.
Patty, thanks for having me, and thanks again for all that you're doing for the industry and all of our teams.